Purva, shall I start? Purva?
Yes, sir. Yes, sir. We can start.
Okay, thank you. Good evening to all of you. Can you see my slides, please? Hello, can you see my slides?
Good evening, sir. We are able to see.
Right. So today what I'm going to do is show some cases which depict the abnormalities in NCS. Primarily, the diagnosis depends upon the abnormalities in the NCS. So you know how the NCS study can help to arrive at the diagnosis. And the minute details of NCS study also I'll be telling about through these cases. Before that, last week, Dr. Sami asked me about the terminal latency index. I'll just 1 minute I will speak about that, then go to the case. The terminal latency index is electrodiagnostic parameter used in nerve conduction studies to evaluate the integrity of the distal segment of the motor nerve. Putting in other words, so when you do the normal conduction velocity is from the velocity between the proximal and distal stimulation. That is the pure velocity. That's only that velocity determines the time traveling around that particular segment of the nerve. But if you take the distal latency, denote not only the time taken for the impulse to pass through the distal part of the segment of the nerve, but also through the neuromuscular junction and the muscle depolarization. So it is not a pure one. So what in terminal latency index means that we are trying to nullify the effect of the neuromuscular junction deficit, delay, and the muscle delay. So just like conduction velocity, we are also trying to measure the velocity in the distal segment of the nerve. That is the idea of this terminal latency index. Now, it is calculated by adjusting the distal motor latency for the terminal distance and the proximal nerve conduction velocity. And lower terminal latency index can indicate a demyelination of the distal nerve. It is useful in conditions like CTS, anti-MAC neuropathy, etc. How do you calculate? It is calculated using the formula. That is, terminal latency index is equal to distal conduction distance, that is distance of the distal electrode to the muscle electrode, divided by the conduction velocity into distal latency. How do you calculate? This is in effect to nullify the effect of the transmission between in the distalmost part of the distal latency component, that is of the neuromuscular junction of the muscle. The distal conduction distance is measurement of the distal distance between the stimulation and the recording electrode and the distal nerve segment. Typical values are specific to the nerve being tested. For example, median latency less than 0.6 is a sign of carpal tunnel syndrome or anti-MAG neuropathy. There are also other studies which can detect this conduction velocity along the terminal segment. One is called the residual latency. This is calculated as follows. Distal motor latency minus the distal nerve conduction distance divided by the proximal motor conduction. A value of more than 2.55 is considered abnormal. The other is you can measure the difference between the minimal FAV latencies between the median and ulnar nerve. That's also another method of calculating the distal latency difference. I think this side, the clinical application is carpal tunnel syndrome, anti-MAG antibody, any condition which affects the distal part of the nerve. Okay, so that much about the doubt regarding the terminal latency index. Now I'll go to the proper case. This case, last week, remember the class which I've taken, the nerve conduction. In these cases, will exemplify what I've taught you in the last class. This is a 48-year-old diabetic lady. This patient came with a history of progressive difficulty in walking in the form of loosening of chapels and imbalance while walking for the last 8 years. 8 years. Is to difficulty in getting up from a chair and slumping to the ground for the last 1 year. Weakness of both hands for the last 6 months. It's a short video. On examination, she had gainless weakness of both hands. Triceps also mildly weak. Triceps was normal power. External rotators were weak. Internal rotators were normal. Wrist extension, finger extension is weak. Finger flexors were normal power. Abductor pollicis longus and abductors of the fingers were weak. Lower limb, both reflexes were weak. Knee extensions were weak. Hip extension was weak. Abduction was also slightly. Adduction was normal. Knee flexion was weak. Dorsal flexion was also weak. Plantar flexion mildly weak, almost normal. EHL was weak. The reflex in the right upper limb all normal. The left upper limb is also again normal, except for the diminished left triceps. Both knee jerk and ankle jerks were absent. Plantar is indefinite. Sensations were normal. She said correctly. This is how she walked. She needed 2% support. She was got a waddling of the gait. Okay, summing up, she has got upper limbs, weakness of all muscles of the upper limbs, except for the normal internal rotators, triceps, wrist extension, and wrist and finger flexors. The lower limb, all muscles were weak except for the adductors of the hip. And the weakness in the lower limb was more on the left side. DTR upper limb, left triceps absent. Rest of the DTR normal on the left side. Artificial abdomen is normal. Lower limb, both knee and ankle jerks were absent. Plantar indefinite. Sensations normal in the upper and lower limb. Gait bilateral waddling, could walk only with 2% support. So this is the story of the patient which has been there for 8 years, pure motor, element weakness, with some reflexive changes, some are preserved. So where is the site of lesion in this patient? What did you
Sir, it
clinically?
seems like a radicular involvement involving the proximal radicals of the upper limbs, mainly C5, some evidence of C6, and in the lower limbs is L1, L2, L3. All the muscles are weak, predominant in an element fashion, sparing the sensory. So I would keep as a motor radiculopathy long standing in this patient, probably a polyradiculopathy of hereditary origin, sir.
Okay. So it's not cannot strictly called as a radiculopathy. It's something like a radicular neuropathy. The pattern of weakness is not fitting with the root distribution. So you better call it as a radicular neuropathy. That means something like you as what you get in, as you said, CADP like pattern. Okay.
Yes, sir.
So yeah, right. So what investigation you want in this patient?
Sir, a detailed NCS including the proximal study.
Okay, right. Any someone else is asking something, please? Any other opinion? Okay, agree with that. Then let us see NCS. This is NCS study. See, this is the median upper limb median conduction, median and ulnar. The amplitude is normal on both median and ulnar. Distal latency is also normal, and conduction velocity is also normal in the upper limb. In the lower limb again, amplitude normal, distal latency normal, conduction velocity normal. This is FAV latency is also normal. Sensory potential all normal, except the left sural, all other potentials were. Now, what do you think about this?
So
Yes,
since
please.
the NCS is normal, we can also have a proximal myopathy, which may show CMAPs normal in the early case. So we should do an EMG in this case.
Okay, is the pattern fitting with a myopathic pattern? See, so if you look at the pattern in the upper limb involvement, it is not a proximal distal involvement like that. Some of the muscles are affected in the distribution of the nerve, some are not affected. So it's not like a myopathic pattern which you get.
Wasting, sir.
Wasting is there. I do not much of wasting. The mind wasting is there.
Sir, the patient is having a long-standing problem, and
Yeah.
weakness, but no much wasting. So the weakness should be attributed to the demyelination or the conduction block, sir.
Okay. Right. Very good.
So
But
distal to the stimulation may be an conduction block or something.
is it distal to the stimulation or proximal to the stimulation?
Pro-
Proximal to
Sir,
the
but
stimulation.
F are,
Proximal to the
yes, sir.
stimulation.
F waves are normal, sir.
If
Still
it's
up
an
higher up, sir.
Yeah, but wherever it is, whether it's a distal part or proximal part affected, if FA has to be, FA has to be affected. The FA abnormality present or presence or absent does not differentiate whether it is distal block or a proximal block. What determines the proximal block is the normal potentials distal to the stimulating electrode. Okay, what you said is correct. So,
You
what
have
the
to
says,
look at the F waves, sir. Morphology of
CAMP
F
can
waves.
be there.
okay, the protein is elevated mildly.
Sir, what about the morphology of the F waves and also?
I'll come to that. So this is the anti-G antibody. Now, what is the diagnosis in this patient? LM lesion, predominantly motor, no sensory. What does the NCA suggest?
Mild sensory neuropathy, but we have to exclude the proximal conduction blocks.
Yeah, there's no sensory abnormality here. There's a proximal conduction block. Statement one answer. It shows that.
Sural nerve amplitudes are reduced in the told, sir.
Pardon?
Sural nerve
Sural.
amplitudes are
Only
less.
one. No,
Yes.
that's a only sensory. Patient has no sensory symptom. That may be due to some local pathology or anything. But here, predominant problem is motor. One absent sural, how is it going to change our diagnosis? So the thing is, remember that when you have to take element weakness to the nerve involvement, if there is a normal potential, that means there is a conduction. Normal CMAP amplitude. Wherever it is proximal to the stimulating electrode. That is a dictum what Dr. Kimura has taught me. So weakness with normal CMAP means proximal conduction block. So these patients put on of 1 gram BD with Visceral 60 milligram OD. Follow up after 3 months. This is the patient. She could walk without support, get up from the chair also. Initially, she needed 2% support to walk about. So this again, to highlight the point which I told last week, that when a normal conduction does not exclude a proximal conduction block. That's the only thing to remember. But your question is very valid. Why not LFA should be abnormal in this patient? I'll come to the answer thing. Because normally peripheral conduction does not exclude demyelination. If there is a why FA is not prolonged? If there is only partial conduction block proximally, FA latency will be normal. This again I have told you last time. Out of the 10 fibers, 1 or 2 fibers are conducting normally. If latency will be normal. Okay. What will you look for in that situation?
Chronodispersion and FA with persistence.
Persistence. So that this is the same thing which I told last time. Okay. Now, any questions in that before I go to this? Is a short case. Long case is coming. And troublemaker is coming.
Sir, should we take it as CAMP, sir?
Either I can call him CAMP means what? Inflammatory.
Like CASP,
Yeah,
sir.
right. Not CASP. SP means
No,
sensory.
like CASP, it's like
Okay,
CAMP, sir.
yeah. You can call it that one. You can call it, right.
F5 of this patient, sir?
If it was normal, latency was normal.
No, sir. F5 waves, sir.
Chronodispersion.
No. This case was done much long back. So at that time, we were not doing this chronodispersion everything, only FA latency. But even with that, we thought it could be a case of CADP and then demyelinating polyneuropathy and put the patient steroid. But there is no other condition which can think, no? 8 years weakness without much of a weak and a wasting, reflexia. So what other condition you can think?
Yes, sir.
Ideally, as you said, you should look for the FA morphology, chronology question, everything. That will come later on. Okay.
Sir, the chronic demyelination is there since many years, no, sir?
Yes, 8 years.
But there is no axonal degeneration and
Till
no
now,
axonopathy.
that depends upon the all demyelin need not produce axonopathy at all. The disease confined only to the axon demyelin sheath, need not produce axon involvement.
Sir, so this demyelination can exist for many years, sir?
Yes,
Typically?
yeah, exactly. This patient, no, 8 years. And she improved in 3 months' time. Subsequently, this patient again worsened on treatment. Then I have to switch over to rituximab. On rituximab, she started improving.
Sir, did you image the nerve roots, sir, of the patient?
No, this patient I did not do. Okay. Now I'll go to the
reflexes in upper limb. Sorry, sir. That reflexes, reflexes in the upper limb, they were symmetrically lost, sir. Upper limb,
No,
sir.
the upper limbs reflexes were all normal except for one reflex.
Okay, sir.
All of the reflexes were normally elicited.
Okay, sir.
Okay, this is a new case, that 70-year-old lady. She's an old case of diabetes mellitus and hypertension. Her present complaint started 4 days back as weakness of the left upper limb in the form of difficulty in elevating the left arm and weakness of the left hand in the form of holding objects and dropping things from the left hand. So proximal and distal weakness. Along with this complaint, she also noticed difficulty in walking in the form that she had to put extra effort to put forward her left left leg. No complaints regarding the right upper and lower leg. Okay. History of paresthesia of the left hand for the last 2 days. This is the video of the page. I think I'll go to this is the history again. 4 days history, left upper limb weakness, proximal and distal, then left lower limb weakness, probably proximal condition has to put extra effort to put forward. That's all, and history of paresthesia. So on no, look at the thing. See, she's got upper limb is edematus. Trainers are normal. Upper limb is edematus on the. See the edema on the left upper limb. It's got weakness at left deltoid is weak. And biceps is normal. The biceps is normal. Deltoid is weak. Brachyradialis is normal again, bilaterally. Biceps normal. Internal rotate is normal. External rotate is weak on the left side. That is weak on the left side. Wrist extension is normal. Very weak, but almost normal. Finger extension is normal on the right side, severely weak on the left side. Finger flexation normal, bilaterally. But see the extension support is longest, almost 0 power on the left side. See, you cannot lift it at all. Finger extensions are also weak. And if you do the pointing index sign, there is weakness of the left thumb and the index finger and the middle finger. Only middle 3 fingers. Lateral 3 fingers. Adductor pollicis is longest is weak. Flexor pollicis brevis is weak. All interosseous were weak. Common sign is positive. She is not. It's actually weak. Adductor is weak. Why it's not flexing? Because the flexor pollicis longus is also weak. The lower limb tone normal. Right hip flexion normal. Left hip flexion is weak. Okay. Knee extension normal on the right side. Weak on the left side. You cannot force against pain resistance. Hip abduction is weak on the left side. Adduction also weak on the left side, normal on the right side. Knee flexion is also weak. Dorsiflexion normal power. EHL is normal. Plantar flexion normal. Reflexes right biceps normal, left biceps absent. Supinator is also absent on the left side. Triceps also absent on the left side. Right side also triceps is elicitable. Finger flexion absent. Knee jack. Right knee jack is left knee jack is elicitable. Right knee jack, both angle jacks are elicitable. You can say the angle jack normally elicitable. Plantar indefinite. Sensations are all normal.
ഈ കുത്തുന്നതും ഇതൊക്കെ ഒരേപോലെ അറിയാവോ? അതേപോലെ ശ്രദ്ധിച്ചിരിക്കണേ. ഇത് ഒരേപോലെയാണോ?
Is able to feel pain equal on both sides.
ഇതും ഒരേപോലെയാണോ? ആണല്ലോ. ഇതൊക്കെ ഒരേപോലെ അറിയാം. ഇത് ഒരേപോലെ അറിയാം. ഇപ്പൊ ഉണ്ടോ?
Temperature is also normal bilaterally in the upper
അറിയാവോ?
vibration is normal.
അറിയാം. കുറവെന്നുള്ളത് ഇതോ? ഇതോ? ഉണ്ടോ?
He is able to feel vibration all throughout.
മടക്കി ഒന്ന് നിർത്തോ?
Joint sense also normal.
ശരി. ഇപ്പോഴോ? ഇപ്പോഴോ? മടക്കിയാണ്.
In fact, joint sense is inconsistent. She is not very cooperating for joint sense. This is where she walked. Some kind of mild dragging of the species dragging her left foot. As if she's left for lower limb slightly heavy compared to the right side. Otherwise, it's a slow, cautious gait. So cranial nerves are all normal. Motor, upper limbs. Left hand and forearm were edematous, which is there only for last 3 days. Her complaint started 4 days back. Tone normal. Power, weakness confined to the left upper limb. Upper and lower limb, but in the upper limb, left upper limb only, not on the right upper limb. Weakness of left deltoid and external rotators. Normal power of the biceps brachioradialis, triceps and wrist extension. But marked weakness of the finger extensors, especially abductor pollicis longus and extensor pollicis longus, which is grade 1. And mild weakness of finger flexion of the left thumb and index finger. We hold like that, this terminal part is not flexing. Something like a pointing index sign. Other long finger flexes of normal. All small muscles are weak on the left side. Right upper limb all normal. The lower limb, again finding confined to the left lower limb, tone normal. Weakness of the left hip flexion, knee extension, hip abduction, hip adduction, and knee flexion. Angle dorsiflexion, plantar flexion, EHL, FHL were normal on the left side. Detail upper limb all absent except for the right triceps reflex, which is just elicitable. Lower limb, left knee jack was absent. Right knee jack and both angle jacks are 1+. Sensations all normal. JP sensation is quite inconsistent, so we cannot definitely say where is absent or not. Vibration is in fact intact. Gait, very suspicious smile dragging on the left leg. So any clarification, the findings, everything you can ask me.
Sir, reflex once more, sir.
Reflexes, I'll show reflexes. Upper limbs, all absent except the right triceps are just elicitable. Otherwise, all reflexes are absent. In the lower limb, left knee jack was absent, right knee jack was elicitable. Both angle jacks were elicitable. Your weakness in the left lower limb is confined to the positive muscles of the left lower limb only. The distal muscles of both lower limbs are normal. Right positive muscle also is normal.
Right
It
upper
looks
limb.
like a patchy radicular involvement of the left-sided muscles. In the upper limb, there is involvement of the both proximal and distal, and in the left lower limb, there is involvement of mainly the proximal. So I would consider a element weakness. The sensory is very doubtful, sir. So it may be a radiculopathy or a plexopathy. There is some involvement of swelling of the left upper limb. So it may be a main and succulenti involving the myeloradiculopathy part. So I would keep a radiculopathy first and then a myeloradiculopathy, sir.
Why do you consider myelopathy in this patient?
So there is some swelling of the left upper limb, which is in main and succulent.
Swelling indicates a sympathetic fibrin, autonomic involvement. Whether it's the peripheral nerve, it also can produce swelling. So that does not say it's a myelopathy.
Looks like more like a plexoneuropathy or a plexopathy, sir, because there is patchy involvement in the upper limb, sir. Fearing more of a plexus or nerves.
Correct. That's a more likely, rather than a radiculopathy. If you look very carefully, the pattern is not fitting with the radiculopathy. Let us see in the upper limb.
Sir, one doubt, sir.
Yeah, please.
The patient didn't have any weakness in the right upper limb itself, sir. But
No weakness.
Her reflexes were depressed, except for the right tricep.
Right, what is it is correct. Except the right tricep, the power was entirely normal right side. Right biceps and supinator was absent. Other reflexes were normal. The right lower limb also, right knee jack was normal. Right ankle jack was normal. Left knee only is decreased. Yeah.
Yes, sir. Sir, since except for the right lower limb, which is apparently normal, even with normal power and normal power of the right upper limb, her reflexes are depressed. So we can consider a radiculopathy also, sir. Radiculoplexoneuropathy is possible because with normal power and depressed reflexes, we have to put the lesion in radical is one point, sir. And the pattern of involvement in left upper limb is since C5 more of I would like to consider a much or a root or a trunk lesion, sir, because deltoid muscle is involved and the external rotation, that is the infraspinatus muscle, is also involved. Both has its supply from the upper trunk part, sir. So more reflexes, sir.
There are many points against that. I'll tell you why I say. I will answer that all of your questions. You see, in last class also I was talking about the term of radicular neuropathy. See, this term radicular neuropathy means what? We do not know. Because every radicular neuropathy can be a neuropathy also. Right? So in these so-called radicular neuropathy, the weakness is not in the distribution of a particular root. Only if the weakness distribution of the root you can call a radiculopathy. For example, let us take this particular patient. Left upper limb. Left deltoid is weak. Biceps normal. Brachioradial is normal. External rotator is weak. Which root can you think about it? You cannot, because it is not fitting with the C5-C6 root involvement. If it is so, you should have got weakness of biceps and brachioradialis. You cannot think of upper trunk involvement. Again, the same thing, because upper trunk is found with the same roots. You can only think of individual nerve affection. That is, left axillary is affected, left suprascapular is affected. Okay, as far as upper limb is concerned. Now you'll take now let's take the distal part of the upper limb. If I told before that this section is normal, but finger extensions are so weak, the abductor produces zero power. Okay, so where can we put that lesion? Only in the posterior interosseous nerve. Yeah, correct. Because not in the, if you think of a radial, possibly triceps should have been weak. Okay, that is not weak. Brachioradial should have been weak. That is again not this thing. So it's something distal to that is the affection. The third point is that this pointing index sign, to get that thing, you can be sure that it is a nerve involvement. No root, no plexus involvement can produce. Plexus, of course, can patchy involvement can produce. Will produce that kind of a pattern. Because the pointing intersection mean what? That is the lateral three fingers are affected maximum. That in the distal part. That's the flexor digitorum profundus is affected. That's typically the distribution of anti-intuitus nerve, not even median nerve. If it's a median nerve, you should get weakness of plexus, so the other fingers should be affected. Here only the lateral three fingers are affected, mainly these two fingers. So this pattern is something like a multiple nerves are getting in. And that pattern is what usually seen in plexopathies. Time again, I have shown many cases of brachial plexopathies where you find the lesion is affecting the distribution of multiple nerves only. Okay. So with here then on that token, we cannot call what is the evidence is a radiculopathy, nothing is there. But pathologically, you may find radicular neuropathy, yes. There may be infiltration information that foods also. But anatomically, neurological localization-wise, we have to say multiple nerves are from the upper limb. The lower limb also, it favors more like a plexopathy because all posterior muscles are affected, distal muscles are not affected. That is the one classically you find in diabetic plexopathies. Not fitting with any root, not fitting with the nerve pattern. Some of the nerves in the primary plexus affected, some are not affected. That is what you get in plexopathy. It's some very, very erratic patchy movement.
Also the autonomic involvement also, no, sir.
Pardon?
More favoring plexus than radical, no, sir.
Correct. Plexus rather than radical or multiple nerves.
Autonomic.
Yeah, autonomic also more favoring a nerve lesion or a plexus involvement. Less likely to be in the root involvement. Especially the lower limb, if you can deem, it's very unlikely to be in the root.
So can MMNC be considered, sir?
MMCB can be considered, no problem. It can be considered only too rapid a progression over 3 days' time.
Okay, sir.
Yeah. Okay, let us see. This is the localization. Multiple nerve roots are affected. Left axillary,
Involvement of lower limbs.
Yeah, lower limb again not fitting with a particular nerve because plexus deep is affected, extensor also affected. Knee extensor is affected. So else you can, adductors are normal. So that means that pattern is fitting in the femoral nerve involved. Okay. Then hip extension is affected. Knee, that fitting is inferior gluteal nerve involved. But the plantar flexors are normal. So it's not going with a sciatic nerve involvement, not going with the root involvement. Only we can explain multiple nerves are affected. And that is a pattern the plexopathy takes.
Sir, does that involve both upper limb and lower limb simultaneously, plexopathy?
Yeah, you are very, very unusual. As you said correctly, very unusual. But what I'm trying to, this is the pattern. The right upper and lower may get involved later on, we do not know.
Yes.
Because right biceps supinatus is also absent. It's only 4 days history.
Yes.
Okay, to the extent that since it's very unusual for left upper and lower limb affected because my assistant doctor said, sir, why don't you do an MRI in this case? Left side only is affected, something in the cervical cord. It's the element weakness. They say, how can be cervical cord? So that's very atypical to affect one side of the body only demyelination is very unusual. Or plexopathy again, same thing, very unusual. That is why this case has been brought here.
So was there any pain before the weakness?
Pardon?
Was there any pain before the weakness?
Patient did not have complete pain at all.
Oh.
No pain.
He was diabetic, no, sir?
Yeah. He's a diabetic.
Yeah, so diabetic radiculoplexopathy, that is the diabetic amyotrophy with neuralgic amyotrophy can present without pain and can have asymmetric involvement.
Yeah. Of course, they can have without pain, and the painless variety is usually bilateral also. And but the pain need not be there all the time. But it is perfectly right. Usually they have because the pain is it more favoring person. Okay. Now let us see. These are the possibilities. Now, what investigation do you need? NCS, correct?
NCS, yes, sir.
Now let us see the NCS. I will show the NCS. Now, the idea of the class today is the electrophysiological approach, because the extension of the previous teaching class. That is the idea rather than the primary diagnosis itself. Anyway, diagnosis is there. I'll come later on. Let's see. This is the lower limb finding, where the patient is only because of positive muscles. This distally we find distal amplitude is decreased. The peroneal ADB is picked up from the peroneal, both peroneal amplitude decreased. TA pickup is normal. Tibial nerve gain from the pickup from the abductor hallucis is decreased. Gastrocnemius pickup is normal. Okay. And the velocity is also decreased, 37, 38, 35. Not gross decreased, mild decreased. And the distal latency is normal. Now come to the median nerve, the affected upper limb is maximum affected. You find the both median nerves, left median and ulnar are all normal potentials. Distal latency is also normal, except for the mild prolongation and the distal, forget about that. And there is conduction velocity is decreased in the upper limb. Now coming to the radial, the maximum affected nerve on the left side was the radial. And the finger distance are also weak. There, the potential was normal. Velocity was normal. Latency was normal. There's a CMAP decrease on the left vastus medialis. And snaps all normal, except the left median. That's also not grossly less than 50%, more than 50%. Still, it is decreased compared to the right. Then snaps in the radial, antebrachial cutaneous nerve, medial antebrachial nerve, saphenous are all normal. FA latency are all prolonged in both upper limbs as well as in lower limbs. Okay, what is your diagnosis after electrophysiology?
So since the CMAPs are decreased with some evidence of a carpal tunnel syndrome like picture of the bilateral upper limb, with normal snaps, we should consider more of a radiculopathy than a plexopathy now, because the snaps are absolutely normal, sir. So I would consider a motor radiculopathy of the left side with proximal conduction block, sir, like you said in the previous case, sir.
Okay, now that depends upon if you have got a sensory loss. Okay, take this point, sensory loss, and then snap is absent. Then you can call it as a lesionis in the nerve, distal to the ganglion. If the patient has no sensory loss, you don't expect a snap to be present, or it inevitably intact only, even if the lesion is proximal or distal. You got the point. Here the patient has no sensory loss in the upper limb, only motor loss. So the presence or absence of snap does not go and differentiate whether the lesion is proximal to the ganglion or distal to the ganglion, because sensations are not affected. The value comes only if you have got loss of sensation. Suppose you have got loss of sensation on the median nerve distribution or some distal part of the hand. And that area, if you pick up the snap, is intact. That means the lesion is proximal to the ganglion. Okay.
Yes,
Here the sensory is not. Yeah, here the sensory is not affected. So the question of snap does not arise to differentiate between proximal and distal. You got the point, Samia? Yeah,
yes,
you got the point.
yes.
Yeah, right.
Yes, sir.
Yeah, in the root avulsion also, some you get a road traffic as root avulsion. The patient comes to you with weakness. The sensory may not be affected much. There, the snap is not going to help you differentiate whether it's preganglion, is a root avulsion or not root avulsion. Only if the sensory loss is there and the stress potential is picked up from there is normally picked up, then you can say it is proximal, a preganglion. Okay, so what do you want to do?
EMG study or a imaging of the proximal roots, sir.
Okay. Now, what I plan to do today is to analyze the EDX. Now, this is, I told you, this case is brought to analyze the extension of the previous class. Let us analyze each parameter. How do you locally? Let us analyze the one. First, let's log limb contextually analyze. See, here you find the amplitude is decreased in the both peroneal, right? Right? And the velocity is decreased and the distal latency is long. Now, where is the site of lesion for this particular? Let us analyze one. So decrease CMAP amplitude from EDAB and AH, that is abductor hallucis. Conduction velocity is also decreased. And normal distal latency. Correct? Let us analyze one by one. Let us take the first parameter, CMAP amplitude is decreased. Which all could be the situation where CMAP amplitude could be decreased? It could be common thing is axonopathy, right? Okay, axonopathy, no? Where the
Yes, sir.
CMAP
Yes, sir.
Second possibility should be a distal conduction block. Okay, due to demyelinating disease. That block may be due to demyelinating conduction block or a nodopathy. Okay, you understood? Because
Yes,
the
sir.
impulse transfer distal to the distal stimulating electrode. Okay, that is the CMAP amplitude is decreased. So these are the possibilities when you get a decreased CMAP amplitude distal stimulation. Correct. Okay, if you have got any doubt, please stop me. Yeah, this is primarily a teaching class for the contextual study. So the word how you normally, yes, please ask.
Sir, it can also be due to temporal dispersion where the amplitude might be reduced and relatively preserved distal latency with the reduced conduction velocity might be there, sir.
Yeah, that's also possible. Perfectly agreed. But what we got was here the amplitude is distal latency is normal. So if you can say that all the as told before, some of the fibers are left behind, distal latency can be normal also. That's a possibility. And unless you find the waveform, you cannot differentiate that possibility. Agreed that, but perfectly agreed. But somehow or other, there has to be a distal conduction block there. Okay.
Yes, yes, sir. Yes.
Because amplitude is low. Ideally,
Yes,
the area should be looked for. Okay, this is the usual thing. So how differentiate, the first thing, how differentiate axonopathy and demyelinating or nodopathy, what will you do? What is the test you like to do?
EMG.
EMG. If EMG shows denervation, no doubt. It is axonopathy, not a demyelinating conduction block, or a nodopathy in the beginning. Late stage nodopathy can do axon degeneration, that's a different issue. So the usual method EMG. But here EMG is not going to help. Why?
only 4 days, sir.
Exactly, only 4 days. The EMG change defibrillation appears much late, depending upon the site of affection. So this again I told the last class. The timing of the ED changes. CMAP amplitude begin to decrease on the day 2 to 3, reach this peak on the day 7. Our patient was done on the 4th day. Snap amplitude begin to drop only on the day 6 and reach the peak only by 10 to 11th day. Okay. And fibrillation appears only by 3rd week. So that means that the absence of fibrillation, point in looking EMG now, because if it is present or absent, if it is very unlikely to be present, even if it is an axonopathy. So your EMG is not to help at this point of time. So you have to get help from some other clues. Since EMG cannot help, let us take other insights parameters for help. Here, look at the conduction velocity is 35 to 38. That is the segment above the distal stimulation. Remember the conduction velocity with normal distal latency. Okay. This makes nodopathy and a demyelinating conduction block unlikely. Can you tell me the reason why? I'll tell you the reason. Suppose if the lesion happened to be between the distal stimulating electrode, is the electrode, what should happen? What should happen?
Distal latency should happen.
Distal latency is the one should
Prolonged.
Right. It should be not the proximal to the distal stimulating electrode. Okay. Okay. So Then you may argue that suppose there is a proximal demyelination, distal demyelination also is there that can cause the block, that is agreed. But in that case, what should happen? I'll explain that thing. If nodopathy, this is the point, if nodopathy and a demyelinated contractile block were causing the distal contractile block, the lesion must have been distal to the distal stimulating electrode, correct? It's simple.
Yes, sir.
Right. The lesion was between the distal and proximal stimulating electrode. You should have obtained normal CMAP amplitude on distal stimulation. Got the point? If the
Yes,
lesion
sir.
nodopathy was between the proximal distal amplitude should be normal. Here the distal amplitude is decreased. Okay, right.
Yes, sir.
Right. So that is a point number one. Moreover, if the lesion had caused decreased contraction velocity, it should have been the distal segment. Here the distal latency is normal. But instead, the contraction velocity was decreased. That is, the proximal to that stimulation is decreased. Let us see this one now. That is regarding the, you understood why it cannot be nodopathy or a distal contraction block?
Yes, sir.
Yeah, okay. If that is there, in fact, distal latency should have been prolonged, but that's not prolonged here. Only the amplitude is there. Now, if the lesion was proximal to the distal stimulating electrode, amplitude should have been normal. Now, let us see the next parameter has got a decreased contraction velocity. Okay. There's an example with the same point. This should have been reversed if it was a lesion distal to the distal stimulating electrode, distal contraction block. This again told last time. The lesion is there distal to the distal stimulating electrode. What you are going to have is a distal latency prolongation. The lesion happens to be between the distal proximal stimulating electrode. You get a prolonged conduction velocity or decreased velocity. Okay. Depending upon the site, this will change. So whether the site of demyelination, site of conduction block determines whether the distal latency is prolonged or the conduction velocity is prolonged. So it is less likely to be nodopathy or a demyelinating block distal to the stimulating electrode. However, this possibility cannot be excluded totally. The reason I'll tell you later on. This much you must remember. Now, next parameter is the decreased conduction velocity is seen. That is between 35 to 30. Yeah. Please ask.
Total conduction block, partial conduction block you have explained previously. Might that explain this prolongation of, reduced conduction velocity with preserved distal latency, sir? The fastest conducting fibers, that is the point where 10 people walk together. Everyone will say
You're perfectly right. Perfectly. That is why I said, that is why I put the last question. Possibility can rule exclude. Because what you said is correct. But think here. Okay. Think of the possibility here. Here he has got a decreased contraction velocity in the proximal segment. Okay, proximal segment. That area is the one which is affected.
Yes, sir.
Okay. In that case, why should the distal latency be normal with a decreased amplitude?
Because we are doing a distal study, we have to do a proximal
right.
study. Yeah.
No, proximal. This is enough. This much is enough. I'll tell you. See, what we got was a decreased amplitude of the CMI potential. If it is axonopathy, wherever the axon loss, the amplitude will be low. That's unquestionable. Axonopathy is number one. If it has to be a conduction block or a nodopathy to produce decreased CMI amplitude and distal stimulation, it has to be distal to the distal stimulating electrode. Okay.
Yes, sir.
If it is possible to that, you will get a distal amplitude should be normal. That fellow is conducting normally, it will be normal. Amplitude will be normal. So that means that this patient had a lesion in the proximal part. Right? Proximal part.
Yes.
Okay. So if that is so, the amplitude should have been normal. Here the amplitude is decreased.
Two pathologies might be there, sir.
Yeah, right. Yeah, that's exactly what I said is perfectly right. You can be a distal conduction block or nodopathy. There must be another lesion proximal to the segment. Perfectly right. That is the possibility of kept it in that position. What is said is correct. Okay, so there may 2% has to be empty. But these cases are only brought to explain the abnormalities in the NCS and how to locally. That's all. That's why initially said the other possibility is this one. Now let's say the conduction velocity part. Any questions in that? You understood, no?
Yeah, yes, sir.
Okay, that is what I said initially.
So should we also do a proximal stimulation with inching method to see whether there is a conduction block proximally, sir? Because the latency is decreased in the distal part.
Yeah, because when there is a decreased amplitude distal stimulation, okay, that means there is distal amplitude is decreased. Whether it's a proximal lesion or not, the amplitude is going to be decreased anyway.
Yes, sir.
Only thing, anyway it will be decreased. Only thing is the proximal amplitude, it's more low. That's the only point we have to get.
Yes, yes.
Yeah. Anyway, it's going to be decreased distally. Ultimately, it has to pass through the distal segment.
Yes.
So now this is the point. However, the possibility cannot be excluded totally because the same reason the doctor was telling, there is a multiple lesion, possible lesion also. Now coming to the next NCS parameter is the decreased conduction velocity. It is decreased with the normal distal latency. This also I told just before these days. Now next question, can this decreased, anyway the CMAP amplitude decrease can be due to axonopathy. Okay, very well axonopathy. So can this decreased conduction velocity be due to pure axonopathy?
The percentage of the decrease of velocity should be considered where it is in a CIDP pattern or a axonopathy pattern, sir.
No, not that
less
one.
than 20%.
This again I told last class that even a pure axonopathy can have a decreased conduction velocity for dilatancy prolongation because what is the type of fiber affected? If large fibers are predominantly affected, what is left behind is the medium and low conducting velocity fibers. That anyway going to have a low velocity. So even in pure axonopathy can have a decreased conduction. And that is why some criteria is there. That means, that I will come later on. So this can produce, see this slide was shown last class. The axon loss can also affect distal latency and conduction velocity. With increasing motor axon loss, largest fibers and conduction will be lost. Therefore, the distal motor latency will be slightly prolonged, but not extreme prolongation will not be there. Invariable demyelination can produce. So that's always less than 120% the normal limit, and conduction velocity is slightly slow, always more than 80% of the normal limit. So if it is more than 80% decrease in the velocity, more than 20% decrease in the velocity, in more than 120% the distal latency, that means it's invariably demyelination should be thought of. But this value can differ depending upon the various criteria. I'll come to that. So in axon neuropathy, slowing correlates with the CMAP amplitude. Hence, the lower limit of normal is not the cutoff to diagnose coexistent demyelination. If we say now conduction velocity is 45, if it is 43 or 40, you don't think it's a demyelination. So this is the criteria by the AN criteria. I think you can skip the first one, distal latency. If the amplitude is more than 80% of the lower limit of normal, distal latency should be more than 125%. Amplitude is less than 80%. Remember that slide only, not the first one. Usually, if it is less than 80%, distal latency should be more than 150%. For conduction velocity, the amplitude is more than 80% of the lower limit of normal. Conduction velocity should be less than 80. Remember only the last statement. If amplitude is less than 80% lower limit of normal, the conduction velocity should be less than 70% of the lower limit of normal to cause demyelination, to say it is demyelination. So putting it in other words, if it is a axonopathy producing amplitude loss than more than say 50% or so, the conduction velocity cannot be prolonged for more than 70%. Okay, if it is more than 70%, then only you can think of something other than axonopathy. So up to 70%, you can have velocity decreased by axonopathy alone. So these are the normal. Let us take our patient now. The normal velocity of the lower limb is 40 meters in tibial and 45 in the conperoneal limb. And normal latency is 4 to 5. Now let us see this same statement. If the amplitude is less than 80% lower limit of normal, our patient has got lower than 50% amplitude. The conduction velocity should not be less than 70% of the lower limit of normal if it was a pure axonopathy. The same statement told for pure axonopathy, if however the amplitude is low, the conduction velocity should not be less than 70%. Now that's in our patient, the CMAP amplitude was less than 80%. And conduction velocity was 35 to 30, depending upon the two nerves. So what is the 80% of the 45 is 36 millisecond. Okay. Okay. If it is less than 80%, that should be. So the degree of conduction slowing can be explained by axonopathy itself. You understood what I said? In our
Yes,
patient,
sir.
yeah, in our patient, it was between 35 to 38. Up to 36, you can expect with axonopathy alone. So this degree of conduction slowing can be explained by axonopathy itself. Okay. So everything in the lower limb can be explained by an axonopathy. Need not think of a demyelinating disease. The lower limb. Then you may ask why the distal latency is not prolonged by the same token in axonopathy. In our patient, the proximal segment is slow, why not distal segment? That should have put a distal latency prolongation. So that may not be obvious because since the distal segment is short, mild decrease in the conduction velocity will not reflect on the distal latency. So that may be an argument by which ideally should be that also should be prolonged if it is an axonopathy. Okay, the axon is throughout. But this may not be reflected in the distal latency. So sum and substance is that the lower limb CMAP amplitude and distal latency normal can be explained by pure axonopathy. Okay. So what is your conclusion in the lower limb motor finding? It's axonopathy. Now the question is it a case of Amman in this particular patient? No. Why no?
Mm.
Because
So it is
was
one-sided, yeah.
Well, that okay. Then no. FA axonopathy, no. Axonopathy means wherever the site of lesion, FA is not going to help. It will be a decreased amplitude. So here the NCS was on the 4th day.
Yes, sir.
There is such a degree of slow amplitude cannot occur.
Cannot occur.
Yeah. So that means this EDS finding must have been there before. Or maybe part of diabetic, that may be part of neuropathy, or maybe partial demyelination condition of distal. Okay, these are the two possibilities. In this case, more likely to be an axonopathy due to an old lesion. She's a diabetic. That is why CMAP is picked up, abnormality is picked up only from the EDB and the abductive hallucis, not from the TE or gastrocnemius. The distalmost muscles are affected. That's why I said more of the patient did not have any significant lower limb weakness. CMAP will decrease the EDB, not in the TA. Okay.
Yes,
right?
sir. Sir, can FF studies be helpful in this patient to show whether there is any proximal demyelination or not, sir?
FA study was done, no? That I'm coming to that. I'm coming to FA is prolonged. That I'm going to explain later on. In this case, both upper and lower limb FA is prolonged. I'll come to that point.
Yes.
Yeah. Now let us analyze the upper limb. See, this idea was to explain how to interpret the NCS abnormality. That is the idea of this class. Now let us analyze the upper limb NCS. See the upper limb NCS, distal latency normal, amplitude normal, but conduction velocity is decreased. Is it significant? Yes, it is significant because the amplitude is normal. You cannot explain that decreased velocity is due to the axonopathy here, unlike the lower limb. So this is definitely abnormal. Now, how far should be the decrease to call it abnormal? This is a demyelination. Now, this is the conduction velocity and bronchial density. See. Now come to, so there is evidence of demyelination in the middle segment. Now, what about the F waves now? All are prolonged. Okay?
Yes.
Right. So what does it again suggest? There is some proximal.
There should be some proximal demyelination.
Proximal demyelination. The axonopathy cannot explain that thing. So what is the norm in F wave latency? So when you call F wave is subnormal, latency subnormal, can you give some margin for that? Any value is there? Usually, simple term to remember is that more than 31 in the upper limb, more than 61 in the lower limb. That's a simple thing to remember. That's how you remember. Now, this actual value, if you take the normal Indian standards, ideally it should be each lab should have its own normative data. This is from the literature. From the median up to 28 millisecond median ulnar, the lower limb up to 45 to 47 millisecond. So what is a prolonged F wave latency is more than 120% of the upper limit of normal is taken as abnormal. 120%. That means F wave latency should be more than 33 in the upper limb. F wave should be more than 54 in the lower limb. If you take this criteria, 20% extra should give you for the margin to call definitely abnormal latency. So in our patient, what we find, these are all above that, well, except in one nerve, all are prolonged more than even if you take 120% is more than is abnormal. Latency prolongation is significant here. So there is undoubtedly FA prolongation suggestive of what? Demyelination. So what is the diagnosis now?
The two lesions, one proximal demyelination and one distal conduction block.
Yeah, correct. So then remember it is present bilaterally. See, the FA latency is abnormal bilateral, not one side. Even though it is what clinical weakness is not there, that means the affection is there on the other side also. Okay, this following.
Sir, the lower limb F wave should be more than 54 or 64, sir?
More than 61 is ideal. 61. Here, if you take the criteria, more than 54 is taken according to this standard. But usually we take more than 61. Now, what I'm telling is that this is from the Indian standard. This is the upper limb, lower limb criteria. You take around, this is the low range, 45. If you take 120% of the 44, 45, it becomes 54, 54. That's why it cost this value.
Okay, sir.
But I frankly tell you, take 61 and 31. That's easy to remember.
Okay.
Okay. Now, this is following video after 4 weeks, for treatment after 1 week.
Maximum
Biceps slightly improved. That remains the same as before. That's normal. But the finger distance is remarkably improved. External rotation is slightly better. So the wrist flexion is good. That is initially also good. The finger distance is good power now.
ഇതിനകത്തോട്ട് കൊണ്ടുപോവാ ഇങ്ങോട്ട് തള്ളു മുറുക്കി ഒന്ന് പിടി മുറുക്കട്ടെ.
Anyway, the biceps has come back.
വലത്തേക്ക് മുറുക്കി പിടിക്കുക.
Biceps also has come back. So the weakness has shown remarkable improvement. And what was the treatment given? Treatment plasma paralysis. Okay, forget about that. Now, I did not show one important electrophysiological finding purposefully because this electrophysiological data was given by the electrophysiologist, the one which I showed you. But what you should have done, you have to send the patient again back saying that you have proximal conduction. The previous NCS, it was not there. See, Up to axilla they are taken, not possible to that. So the same day as the electrophysiology do the repeat conduction with the proximal stimulation, I will show that thing. This is the lower limb pocket. This is the value. The same day, the previous NC said the same day. If you do the EBS point, not stimulated.
Proximal conduction block.
That's a conduction block proximally.
Yes.
Yeah. So that is what I said. When you get a weakness with a normal CMAP amplitude, think of a proximal conduction. These CMAP which are all normal, if you take normal by standard, but there's a conduction block proximal. And that is what has caused the weakness. Okay. Now let us see the FA traces. You expect some FA abnormality also apart from the prolongation. See the abnormality there. Only 4 FAs are seen. And this right peroneal is also grossly, FA persistence is decreased. Left tibial again decreased. This is right median, which is a normal nerve. The FA is relatively good. Right median nerve is not affected. Left median is the one affected. This is a left median which is affected. You saw the pointing index and all. See the FA pattern. Left ulnar nerve again is decreased, not to that of median nerve. Left radial CMAP is normal. This increased chronodispersion as well as persistence in the affected nerves. Now, 7 days after the first visit, when she came for follow-up with improvement, a repeat NCS was done. Forget about the lower limb finding. This is what is happening in the upper limb now. The so-called normal potential has become decreased now.
More apparent.
Yeah. So the amplitude has become decreased in the median nerves, but not in the ulnar nerve. But radial still continues to be showing no abnormality. And the right axillary deltoid, which was normal initially, has become absent, and the right muscular cutaneous biceps also decreased. FI latency is seen. So this is the old one and the new one. I think lower limb, there's not much a difference. I will skip that thing. Come to the median now. See the amplitude on the right median is decreased in the second one. Distal amplitude compared to the proximal. The one on the left is the old one on the right side is the recent one. So how to explain the decrease with the improvement also? There's a decrease in amplitude, distal amplitude now.
So the NCS abnormalities may persist despite clinical improvement.
Right.
That is one explanation, sir.
Right. Second thing is that the demyelination must have become manifest later on. See it has progressed to, this is seen in the median nerve. That median nerve has not improved. What is improved is the radial nerve, muscle supply, the radial nerve is which is improved. There the amplitude has not increased. So always you have to have a clinical correlation. Which are the muscle nerves is improved, which has not improved. Okay, that is why this disparity is occurring. You can separate the distal segment as well. Now on the left see the right axillary, which was not affected earlier, the amplitude has become decreased. So also right muscular cutaneous. Right radial, remember it is just improved, that amplitude has not become decreased. FI latency is same. So conclusion, final diagnosis, demyelinating polyneuropathy, atypical presentation with unrelated axonal neuropathy due to diabetes. Okay. So any questions?
Sir, one clinical question related to this. Since there was a swelling of the left upper limb, which is more of a axonopathic clinical sign, that is a small fiber involvement, can it be explained by the proximal demyelination, sir? The swelling?
No, it's difficult to explain, but some or other that is affected. No, demyelination can affect. I mean, a pure demyelination, small fiber, the autonomic fibers are unmyelinated fibers. Okay, that is correct. But this Whether it can involve the demyelinating disease does not mean that only confined to the myelin sheath. Can also have the small fiber also. For example, in GBS also you can have pain loss also.
Yes, sir.
Yeah, so can affect the other nerves also.
The second question is that if we are considering NCS to be a prognostic tool, then how long we should wait till we get a correlation between the clinical improvement and the NCS improvement, because we are getting NCS.
That is very difficult to predict. See, I have done some more cases, the patient almost totally improved, but NCS abnormality is persisting. That does not direct correlate. When it will come, how long will you wait to do? We do not know. This is applicable in nodopathies, yes. Serial conduction, you can find that we know whether the nodopathy is a reversible conduction failure or it's a nodopathy has gone on to axonal degeneration. On follow-up after that, again, wait time varies. Some people, the reversal can occur in 3 weeks. Some people may take 3 months.
Sir, clinically, how long should we wait, sir, for any improvement in demyelination?
In a clinical weakness.
Yes, sir, weakness.
Okay. No, again, I know all you must have seen number of ADPs. No, the improvement pattern totally unpredictable. Totally unpredictable. You may think that patient may improve in 1 week's time to one IVIG, second IVIG, and plasmapheresis, still no improvement. Patient goes on to axon degeneration, Amman type and bedded. Other patient without anything, had a patient who come with weakness. 1 week she became all right. No treatment. Reflexes still absent. But there is a weakness improved. I do not know. This all depend upon the severity of the antibody damage to the nerve. I cannot know. How can we say how long to wait? We cannot say. It's highly individual variation. That is my experience.
Sir, usually how long you wait for taking up for plasmapheresis in AADP, sir, after IVIG? Patient is not improving clinically after IVIG.
Right. Again, difficult question to answer. Some people say up to 2 weeks, but I wait for only 1 week, maximum 1 week. If not respond, I'll go for that.
Yes. Thank you.
Again, depending on the severity also. Suppose it's a mild weakness, still we can wait for the, we would say life-threatening situation like respiratory involvement, I will not wait for more than 1 week. The highly individualized, depending upon the scenario, patient degree of weakness, everything determines that. Okay, is there a time for one more case? I'll stop.
Sir, one more doubt, sir.
So one more case, one more case.
Doubt first, yeah, please.
Sir, actually, when you're saying something about the absolute value, we can, like an eyeballing, upper limb, if it is more than, how much should we consider abnormal, sir?
In FA, you mean?
Yes, sir.
FA upper limb 31, lower limb 61.
So up till that is okay.
If it is less than, up to that, it's okay. It's a general statement.
Okay, sir. Okay, sir. Thank you.
Right. I think this case is a long case. I will go for a short case. This is a very tough case also. I will give it next time. I think I will show this case. This is a short case which will be over in 15 minutes time. So, pain. History of pain in the right thigh and shoulder is a 15-year-old boy. Pain in the right thigh and shoulder region 1 week back, followed by same day by difficulty in walking and difficulty in getting out of the chair. No sensory complaint. Weakness has slightly progressed for the last 2 days. On leading question, he gave history of fever 3 days back. I think I'll skip that one. That's not a very interesting case. I'll go to that a better case. Suddenly, when you ask me to choose, I didn't find it. Make it a good case. I will say just one more thing. Okay, I'll choose this case. Okay. This is a good one. This is a story of a 21-year-old male. His complaint started as difficulty in buttoning the shirt with right hand 3 days back, following a dance practice 1 day prior. 1 day later, he noticed difficulty in writing and washed his face with water with the right hand. No complaints pertaining to the left upper limb or both lower limbs. No paresthesia or numbness. So this is a complaint. After dance practice, he noticed difficulty in buttoning the shirt 3 days back. But the proximal muscles were normal, biceps was normal bilaterally, triceps normal, this section was normal, finger flexors weak bilaterally, more weak on the left side, finger flexor was normal. The wrist flexion was also weak bilaterally. Flexor pollicis was normal. Small muscles were weak bilaterally. Flexor pollicis brevis was weak. Flexor pollicis long was normal. Interossei were weak. The dorsal interossei were weak bilaterally. You can see mind wasting also, you can see that. Comments was positive bilaterally. The main effect is both small muscles of the hand. Lower limb, weak spasticity right lower limb, not very convincing. Lower limb power was all. The mild weakness is distal part. Bilaterally distal. Okay, abductor. Now reflexes. Right biceps is absent. Left is absent. Right supinator is absent. Triceps is well elicited bilaterally. And you can say the inverted supinator jerk. Bilaterally, finger flexion jerk is brisk. Abdominal reflex intact. Knee jerks bilaterally brisk. Ankle jerk also well elicited. Plantar indefinite. Or flexor. Sensation is normal. Normal. Joint sense normal. Walk gait is also normal. You can walk on heel and toes. You can get over sitting spell. An examination, wasting of thenar hypothenar muscles with the right hand. Mild stiffness of the left lower limb, no spasticity noticed in the legs while walking. For upper limb, normal power of the shoulder girdle and shoulder and elbow muscles. Mild weakness of wrist flexors, finger flexors, finger extensions on the left side. Mild weakness of the finger extensions on the right hand. Weakness of small muscles of both hands on both sides. So, small muscles are weak bilaterally. Finger extensions are weak on the right side. On the left side, weakness of wrist flexors, finger flexors, and finger extensions. Slightly more weak on the left compared to the right. Lower limb weakness of both dorsal flexors. DTR upper limb, both biceps supinator absent. Triceps finger flexion reflexes well elicited. Inverted supinator reflexes both sides. Both ages brisk, angle jack brisk, plantar indefinite, abdominal reflex intact. Sensory system normal. Gait normal. So where is your localization?
Sir, what was the duration of the illness?
Duration is 1 week. He had a dance practice, 3 days. Dance practice, after that he noticed clumsiness of the left hand. Both hand more on the slightly more on the right, left side.
Sir, it looks like diffuse involvement involving the C6 to C8 because there is wrist flexor involvement as well as the small muscles of hand involvement, radiculopathy. And since it is very acutely present in this patient, and after a dance practice with some trivial trauma, we should consider a myeloradiculopathy in wake of an increased supinated inversion with increased finger flexion. So a myeloradiculopathy, probably a underlying Hirayama with
Okay, yeah. So I think what you said is correct. Can say you don't say C8 radiculopathy because finger flexion is a brisk. So that means it has to be UMN type because
yes.
So C5, C6, that is inverted supinate to indicate that C5, C6 segmental root involvement. Below that is one thing you have to keep in mind. Agreed. Any other different thoughts? All agreed?
There was some clawing in that hand, sir. What was the pattern of the clawing, sir? We saw in the examination.
Yeah. There is mild wasting was there in the small muscle of the hand. Clawing was not very obvious.
Okay, sir.
Yeah. So this is patient came with this MRI. Exactly C5, C6 level. Yeah, here, this is a sagittal, axial cut, this is axial cut.
So flexion extension films?
That I don't know, it was done. He came with MRI. I did not do any further investigation. This MRI patient was, came with. Now, what do you want to do now?
NCS should be done, sir, with EMG.
Why do you want NCS for?
Wasting is there, sir.
Yeah, correct.
Yeah.
That means something long duration is there, no? Okay. Right. So this NCS was, this is NCS. The ulnar distal latency is slightly long. Otherwise, right ulnar, otherwise normal. Left was normal. Amplitude was normal. Peroneal, again, mild distal latency prolongation in the right front. That is unaffected limb. Had no weakness in the right lower limb at all. But here the lower limb also there is mild prolongation of the contraction velocity. Sensory normal. So what will you like to do? Surgical conduction.
CSF study. Yeah.
Surgery consultation.
Yes, sir.
Okay. Was it a case cervical disc prolapse? See the waveforms now. See the waveform in this patient. What do you find the waveform? Dispersed potential.
Dispersed potential. Yes. Demyelination.
Yeah, right. So again, dispersed potential, left peroneal. NC is done on the next day. See, it's got a conduction block. So don't believe on the first day conduction. You may dare later on. Okay. So the finding, see, you make it brisk reflexes in GBS. Remember that point. Brisk does not against the GBS at all. Here also you find the reflex is brisk. The muscle, the finger flex is very weak, but that reflex is brisk. Radial normal. Again, the velocity in the distal part is also prolonged in some of the nerves. Sensory potential normal. If wave is prolonged in two nerves, it is prolonged. Patients given IVHE, improved the IVHE. So patient totally improved after 1 week. So in fact, what is the thing which made me do this repeat conduction and think away from compressive myelopathy? Can you tell me that? What was the
Acuteness of the presentation, sir, and the lapse must be long duration.
Correct. Acute, exactly. Is such a one more thing. I'll show the finding also. See, this is a chronic disc. This is not acute disc.
Yes, sir.
Yeah, acute. This is a chronic disc which is there. But that cannot cause this kind of acute presentation. Okay. So uniform radiology.
Sir, how do you say it's a chronic disc, sir? Looking at the image, it looks like a ossified posterior longitudinal ligament.
Exactly. Calcified. It's a calcified lesion. Her presentation was acute.
His age is 14 years now.
Yeah, 14. That's it. See, it's the calcified disc totally agreed with you.
Yes.
But his presentation does not go with the radiological finding. That's the thing you have to find. Okay, secondly, he had got a wasting of the small muscle. How can a 4-day weakness produce wasting? Okay, and he has no root pain, no sensory complaint, only weakness. If there's an acute discompression causing some kind of a root pain or something should be there. So you have to always, before embarking on the radiological community, try to think whether it can go with clinical finding or not. Otherwise, you will be misled. This patient only because because why should wasting occur? There's no pain. There's no tallying with our finding. That is why I asked for a repeat conduction, which made out there and looked at the waveform showing a dispersed potential. And improved markedly with treatment. Okay. When the
Sir, one
CMAP
clarification.
Yeah.
Sir, as the previous doctor was telling that why can't it be in a case of an acute myelopathy, sir? We had a patient of Hirayama disease who had a trivial neck trauma and he presented with an acute wrist drop. And the clinical picture and the NCS was exactly like your case, sir. So can a Hirayama present with an acute myeloradiculopathy and show this similar picture, sir?
No, Hirayama can produce acute presentation, can known, but here it is no doubt about it. He has got a conduction block. How can Hirayama produce conduction
Yes,
block?
sir. In this case, it is obvious.
Disperse potential. You cannot get any time to spot lesion of the compression wherever it is can put this finding. Disperse potential mean demyelination. Distal conduction block means distal brain. No question about it.
Yes.
Demyelination in multiple nerves.
Multiple nerves. Yeah. It's a GBS. What do you have GBS?
Okay. Again, wasting in GBS.
Yeah, wasting. Yeah, that's what you said is correct. So wasting is most likely not due to GPS. That must have been due to the disclusion bodies, the ischemic, something like that. But that's again another clue that wasting is not due to that.
If we are getting a picture like this in a young patient like your patient, sir, we should always do a flexion extension study with contrast to see whether there is any underlying Hirayama, sir.
Yeah, but here it is not required. In some other cases of compression, as you said, we should do. Not only Hirayama, even other mild, sometimes you get only mild discompression. The pathology, the compression of the cord can be made out only by flexion extension. This case also I showed 2-3 cases before also, where the compression is made out only by extension of the neck, not by flexion also.
Yes.
So always do both flexion and extension to compression. Compressive myelopathy also you should do like that. Okay, so shall we call it a day?
Yes.
Thank you, sir.
Okay,
Thank you, sir.
Thank you,
Sir, you
sir.
should
Sir.
arrange.
Thank you, sir.
Nice.
Thank you. Thank
Sir,
you.
you should arrange a two-month fellowship under you for NCS because, sir, we are all lacking in the field of NCS. You should all, sir, try to do that in the future.
No, I have prepared. There are 10 more cases showing this kind of a typical NCS interpretation. I'll tell you. Subsequently, I'll be taking regular classes. In between,
Thank you
I'll
so much, sir.
indicate on this end. Okay.
Thank you, sir.
Indicate what.
Thank you, sir. Good night,
Thank you
sir. Good
so
night.
much,
Thank
sir.
you. Good
Thank you
night,
so
sir.
much, sir.
Thank you,
Thank
sir.
you.
Good night, sir.